Hello and welcome to the Center for Medical Justice. I'm Dr. Joseph Parker, and today I'm going to be speaking with Dr. Mark Ibsen. Now, Dr. Ibsen has written a book called Dr. Bison's Fables, which is an allegory about the pain crisis in America. And he was also featured in a film called Pain Warriors. Who had helped produce that?
Tina Petrova was the producer,
That's it.
and Brian Weiss, and it's released on Gravitas Productions, and it's now free on Tubi.
Oh, wonderful. Well, I saw it's on
Yes.
many platforms. And I
Yep.
wanted to ask you now, I know you were targeted in 2013, but can you give us kind of an idea of what you went through?
Yeah. Okay. How many weeks do you have? Or how much of a bank account do you have is really the question. So I did an emergency medicine practice from 1983 until, well, really 2012 or 13 or so. At one point, it was like tiresome and late nights and that, and so I decided I'd open up an urgent care practice, and so I did that. I did a family practice residency, so I had some family practice interest, and I had some natural medicine interest from some of my travels, some spiritual interests, and I really started off with a dream of being a family doctor. And medicine was narrowing too much at the time I was looking at trainings. So I went into family medicine, and then I realized that, oh, well, emergency medicine fits my lifestyle and my personality. So I grandfathered into emergency medicine and practiced ER for about 35 years. So the urgent care was opened in 2010, and I co-located it with some friends of mine who were naturopaths. So my business was called Urgent Care Plus. Their business was called Natural Medicine Plus, and we were each other's plus. And it was phenomenally enriching. The people who wanted to get natural medical care were kind of allergic to doctors and afraid of them. And so I could be kind of a guide into the conventional medical model for people who were afraid of it or hostile to it. And then they had the healthiest patients in town, either because they had money to buy um, uh, uh, supplements and stuff, but they certainly had the most expensive urine in town. But those patients were clearly they were healthy. And my patients who are having trouble getting healthy in the allopathic model, I referred to them. So it was a very rich back and forth kind of, it was almost like being in a training program for each of us. And we presented each other's cases to each other, and it was just delightful and rare, and it offended somebody. I wonder who. um, but around 2012 or 2011, a patient came in to see me, and he said this. He said, I've been a patient of Dr. Burkholder's. He's had me on 4 Lortab a day for 15 years. Dr. Burkholder just retired, and Dr. Wampler won't write this prescription. And he came in on a Friday. He'd been to the doctor already. He knew he was going to be in withdrawal tomorrow. And I thought, I kicked this can down the road for 35 years as an ER doc, and now I'm down the road and the can's been kicked to me. Now, I could kick it further, but it seemed to me, the blessings of being an ER doc is you handle everything. In fact, I used to answer the call when someone would call from an outlying hospital. Hi, this is Dr. Ibsen. How can I make your problem mine today? And so I'm just kind of like codependent in that way, I guess. And I'm used to just taking anything that comes. And I was new in the outpatient setting, and kind of like Rip Van Winkle. I'll get to that in a minute. So I just said, okay, I'll help you. You don't have chronic pain. You have acute pain from withdrawal and abandonment. And this set a series of events in motion. I remember I decided specifically to do this. I'm responsible for what happened at some fundamental level. And I began to see more and more patients that were in that dilemma. I missed the memo where all the doctors in Montana took a step backwards, and I didn't see it. And all of a sudden, I'm the volunteer. And it seemed like this is a public health crisis. I called the Department of Public Health and Human Services in the state, and I said, people are being destabilized and thrown into withdrawal for arbitrary reasons. Can you deal with that? And they said, no, nobody was interested. Ultimately, a lot of patients came to me for help. I got about 80% of them off of opiates using alternative methods, some of which I learned from my natural medicine colleagues, and craniosacral therapy and physical therapy and prolotherapy. And I had a chiropractor working for me at one point who was an x-ray tech also. So it was an opportunity to really do an abundance of things. My naivete was that I kind of thought that excellent customer service would be rewarded. And it turned out that I was working in a McDonald's environment and trying to serve with fine china and linens. um, you know, all the administrative stuff that I wasn't really familiar with. So I was flooded with patients, and I was getting successful with them. The chiropractor I had hired was anti-opiate, and she filed a complaint against me with the Board of Medicine, violating HIPAA rights for 9 of my patients, and essentially she was not on board with continuing patients' medicines that had been on them. And you know, my patients mostly weren't either. They wanted out of this gilded cage they found themselves in. Nobody informed them that they'd be dependent on these pain medicines or that they could be abandoned. So most of my patients were really eager to get off the medicines. And so that I call those patients the low-hanging fruit. They were easy, and they were motivated to never let anybody in control of their pharmaceutical life again. However, there's 20% of those patients who I couldn't successfully wean. They were on higher doses, and they failed to thrive off of their opiates. They were dying before my eyes. And somewhere along in here, this Board of Medicine complaint got legs. I thought they'd give me a trophy for what I was doing. Well, they did, but they lubricated it real well, and it's in a shady place right now. So, so, it sort of backfired. But what I started to learn more and more and more about these pain patients and how kind of the state kind of pushed them into a silent epidemic of agony and suicide. So the board had this case against me. This was in 2013. It was before the CDC guidelines, but it was in the same fake news realm as, oh, well, pain patients are bad. Giving patients pain medicine is bad. There's an opioid epidemic. And that story sort of goes like this. Johnny was the high school quarterback. He breaks his collarbone. He gets 20 Percocet. 7 years later, he dies of a heroin overdose, and it must have been the Percocet.
Right.
And I'm like, I haven't seen that. I've seen gamey patients come to the ER forever. Right. And it was my pleasure, particularly in the middle of the night with no one else to talk to, I would really listen to their whole story and get it that, yeah, these people are in the wrong place to get what they need, but there is no place for a lot of those patients. And I did a lot of volunteer work across the world doing refugee medicine, with people from Syria who were going through Greece, or patients in the Himalayas working with the Dalai Lama. I worked with Mother Teresa in Calcutta in 1989. And so I could see that, poverty is a factor. Caste is a factor, more outwardly and evidently in India, but there's a caste here too. And so I had been comfortable MacGyvering stuff for people and trying to figure out how to solve their problem. In fact, what I used to say to patients, Joe, is, may I call you Joe?
Absolutely.
Okay. I would say to patients, first thing when I introduce myself, I'd say, I'm Dr. Ibsen. How may I serve you? And then after we get the joke about a hamburger, then they actually feel like that transforms their experience. Like I'm there to work with them, not as their boss or their patriarch or some higher up than them. It's basically you and I are together. We're going to discuss you. And then I would promise at the end, I think we can help you. And in fact, I'm going to stand by you until you're restored to health. And people would weep. And I didn't used to say that in the ER because I couldn't. In the
Right.
ER, what I would say is, I know you're in pain. The nurses are drawing up your morphine right now. I want you to know this. We have more medicine than you have pain. And that decreased people's needs by 50%.
Absolutely.
And I can't say that anymore either. So at any rate, the Board of Medicine thing got involved. We ended up in about a 10-year battle where they claimed I was overprescribing. I proved I wasn't. They were mad at me for standing up to them. So they punished me by criticizing my documentation. And they did that by ordering 2 sets of documents from me, and they scrambled one of them, the briefer one, and sent that out to their consultants. And I got the feeling that I was being made an example of, that I was a scapegoat. So they ended up criticizing my documents after scrambling them, and made me take a documentation course. And so even though they suspended my license, the district court judge overruled that suspension, saying that they had violated my due process rights. And they ultimately just put me on probation and made me take some documentation courses. This resolved somewhere around 2018 or so. Around 2015, my assets were seized in my clinic, and for some reason, I don't know why, the employees wouldn't work as volunteers, and so
Just
my
not
clinic was
dedicated
shut.
anymore. It's sad.
Right? Yeah. So my clinic was shut down in 2015. And I couldn't sell it, and it was a big loss, and it was terrible. I invested about $500,000 in legal fees fighting this thing with the board, and it went on 10 years. They just would make me hurry up and wait, just constantly twisting in the wind. Might have been why they were upset with me. I don't know. And around 2017, Dr. Christensen in Montana was convicted of manslaughter for when he was charged with 400 felonies on 11 patients, which is about, I don't know, 9 felonies for patients, something like that. So he went to prison, and I said, I can't do opiates anymore for patients. I'm going to be arrested. And I quit. And after that, 6 of my patients died.
That's the sad thing is, first for some of the non-medical people, it's not often recognized. Anesthesiologists consider themselves the pain specialist, but ER doctors see more pain in a day than an anesthesiologist usually sees in a week, and more different varieties of pain.
And there's one other thing to that, Joe. There's one other thing that goes along with that. What is the condition an anesthesiologist sees all of their patients during their training? They're asleep.
Yeah, right. Yeah.
So they might think they're good at listening to patients, but they're just listening to them snore.
And the beeping sounds.
Yeah.
But
yeah.
When it comes to interventional pain medicine, they do.
Yeah, those guys
go
are
through
good.
exceptional training. When it
They
comes to medical pain management, an ER doctor or an internal medicine doctor or a psychiatrist can learn how to manage the medication as good or better than any anesthesiologist. So,
before 2012, 80% of patients' pain was managed by primary care doctors.
absolutely.
Just
And
like
I remember
blood
that
pressure.
era. I remember that era. I mean, in my career, I went from the 90s where they're saying, if people aren't screaming in the cancer ward, you've given them too much, to the 2000s where they're saying, if anyone is still in pain, you're a bad doctor and we will jerk your license, to 2012, right? 2010, opiate prescriptions peaked. 2012, they're heading down on their own. Nobody locked up, nobody framed for murder. And then 2013, they start moving on some doctors, but they're having trouble because they don't have a speed limit sign. Then 2016, the CDC is kind enough to say, here's your speed limit sign. And they clearly said, don't apply this as if it's to everybody, and don't apply it to patients already on opiates. Of course, they ignore all that. And so then things really start rolling. So as doctors are abandoning, and I agree with you, I feel like there was a memo that went out, a secret message I did not decode, where all the other doctors were told, if you keep treating pain according to your education, training, and experience, we will lock you up. And they all said, oh, okay. And I somehow didn't hear the message. And I thought I still had the right to take care of my patients and not let them die. So
exactly.
You end up being the last person standing in a certain area. Everybody's coming to you. You're trying to manage them and get them down off medications, but that's not enough. You can cut some of their medications on the first visit. That's still not enough. And I won't go into my travails right now, but
I've read about them.
it is sad that the doctors who are trying to save lives, and as ER doctors, and that's what I was also before, that's our reflex. We're going to save you. We're going to help you. Whatever's going on, we're going to try to make it better, send you out. And before, we would hand you off to your primary care doctor once either we get old or the hours get old, something, and we don't want to, be up 24 hours at a time. So we start doing general medicine, which is a breeze, urgent care, as you say. Urgent care is a breeze after you've done ER, and general practice, you just extend things a little bit. I went to Harvard for the pain medicine for the primary care physician and all that. When they came after me, they made fun of that. They sneered at that. They said, "You're real proud of that little certificate, aren't you?" And I said, "Well, it's from Harvard. I'm kind of proud of it. It was an honor to go there." Um, all of these things that we think will be in our defense, they can twist in imaginative ways. Now, you've written a book, and it was written allegorically. Can you tell me what prompted you to write it that way? It's very unique. I found it very interesting.
It was my publisher's idea, and I didn't like it at all. But he was right on, and I'm I use so many consultants in my career, in my practice. I figure if I'm paying somebody to do something, I should actually seriously consider the advice I'm paying for. So I go to my publisher and I go, I'm going to write this angry screed and tell people what's happening and what's around the corner. And my theme is that pain's a terrorist. Oops. Can you bleep that?
I can bleep that. I
okay.
That.
And it terrorizes people. It disables them. It shortens their lives, costs a huge amount to our economy, according to the Institute of Medicine. And so I'm doing a service not only to my patients, but to society. And I'm saying, what is the problem with what I am doing? People promised. It's like putting a pain pump in a patient. You put a pain pump in, they're committed to that for life. Just like if you put a pacemaker in, we're not taking it out. We might replace the battery, but
right.
Whoever decides you're getting a pacemaker has made you a pacemaker patient the rest of your life.
Right.
And same thing with a pain pump. Well, whoever starts somebody on an opiate has decided that you're going to be on opiates the rest of your life or have a hard time coming off. But we do that in other realms of medicine. If you have cancer, we start the clock. We give you chemotherapy, and we have a race between whether the chemo kills you or the cancer does. And if the cancer doesn't kill you, then you got to recover from the chemo. So we all have to recover from the various medical challenges that we get. We don't have a time machine right yet.
Right.
So we can't go back and undo the accident that people have or the autoimmune illness they developed. So it's been extremely challenging. And I got to tell you, it's been very rewarding. I mean, I used to save one life maybe a week in the ER, and see a lot of ear infections and bronchitis and stuff.
Right.
Now it's like every patient who sees me, they keep close track of my well-being. They're and not only because I care about them, that's the number one thing, and they care about me. But the other thing is if Monday rolls around and you don't have your medicine, you're in trouble. And these patients were looking for relief when they found me. So it's been agonizing and horrifying, but also really stimulating. Made me learn a lot and maybe let go of an awful lot of resentment.
That's good. That's good because it's, being bitter always damages us much more than it does whoever we're mad at. They're actually happy that we're mad. That was their goal. So you've been in this a little more than 10 years. And are you still doing non-narcotic, pain management, I'll say, or non-narcotic?
Yeah. So I do. I have a cannabis practice. In Montana, cannabis became recreationally legal 2 years ago. There's still patients who want a medical card because they get less tax and a higher intensity of their product.
Right.
With the medical. So that's still going. I do some. I've been involved in a couple studies on outpatient use of ketamine for pain relief, as well as I've had a couple patients with severe depression that have been helped with that.
Ketamine in a moment. I'm going to chat with you a little bit about the cannabis. Now, cannabis was approved. Now, I always say that there are 4 things that, for the physicians watching, there are 4 things that get a doctor targeted. a patient that you had to dismiss from controlled medication therapy because they wouldn't follow the rules. That's number one.
Yeah.
Number two is a disgruntled former employee,
Got
someone
that one.
you
Yeah.
had to let go, and man, they can just really roast you. The third was a jealous competitor. And now I have to add
Got that too. Yeah.
a patient who dies from any cause while on your controlled medication, because they
Yeah.
could die in their sleep at the age of 87, having been on the same dose for 20 years. The government will still say that your medications contributed to their death. I'll give you an example. A doctor just got 20 years in prison because a patient of his died from a cocaine and heroin overdose after he had been prescribed about 20 oxycodone. So they said, well, there was still some oxycodone in his system. So even though he died from a speedball, heroin and cocaine injection, which took out Jim Belushi, they said, even though he died from that, your oxycodone contributed to it and you put him at high risk. And that's something I want to discuss. So now, with the cannabis, you're certifying people that they have a condition that the state of Montana has determined allows them to try cannabis therapy. And no matter what
Yes.
someone's opinion is on cannabis therapy, when it does not kill people directly. No one, there's no toxic level of cannabis anyone has found. A bale will fall
You'd
off
have to
a
be
truck
hit
and
by a
kill.
bale of it.
That's exactly right. A bale will fall
Yeah.
off a truck and kill somebody, and they'll say, aha. But and it does help some people. Now, my experience with it was that for most people, it makes their pain and anxiety a little better. A few, it makes their anxiety a little worse or causes some nausea. So those people you take off of it, maybe you get a THC-free CBD and have them try that, because sometimes it's the THC they can't tolerate and the CBD is okay. They are not the same. They act in different ways. So I also found that I was the first in my area to agree to certify people for medical cannabis when Arkansas passed their law. And a doctor across the state border called the DEA and said he's going to be selling marijuana out of his clinic.
Yeah.
So these
How nice.
competitors.
Thank you so much, Dr. X.
Yes, and I'm saying, you could have called me and I would have explained, actually, no, I'm not. You just certify that they have rheumatoid arthritis, or you certify, and whether you believe cannabis works or not, at this point, these poor people are suffering horribly. They've been through every operation, procedure, shot, and steroid that you can imagine. You're saying, hey, let them give it a try. If it eases their suffering, it's safer than NSAIDs kill more people every year than heroin, and it's very hard to make people understand that. And I feel like the DEA is ignoring the risk of not treating and helping someone when they have severe chronic pain. That they're saying, well, you put them at risk of addiction. And I draw the parallel with orthopedic doctors and say, every time, if I give you an antibiotic, I put you at risk of an antibiotic resistant infection. I put you at risk of MSSA or MRSA. And
C. difficile.
yes. Yeah. And no one comes to lock me up saying you put them at a high risk of, but when it comes to opiates, and I'm worried about ketamine now, because Matthew Perry took ketamine he should not have, a lot of it, was injecting it, took a nap in his hot tub, which is really what happened. He passed out in his hot tub.
He drowned.
Yes, and he drowned. He did not die from the toxic effects of ketamine. He passed out from the ketamine that looks like people were injecting. I read the coroner's report. I did an analysis of it, and now they're screaming and ranting. And now that no one wants to treat pain with opiates, I see them starting to target doctors for treating with ketamine, even though it's FDA approved for the treatment of multi-drug resistant depression and depression with suicidal ideation as Spravato, right? So I could spend, thousands of dollars on a nasal spray, or just get an IM injection because it's cheap as dirt, because we've used it in the ER for 30 years. It's the racemic mixture probably. And it's cheap. It's cheap. You can also get a powdered form in a capsule that Harvard had recommended that at 25 milligrams up to 3 times a day. And then you can bump it up to 50 milligrams up to 3 times a day. But now I hear the DEA going on the news saying, these doctors, using ketamine and all this. And I'm very worried. but that they're going to take that tool away. And I would argue that people do not become addicted to ketamine in the classic way that we think of addiction with opiates as activating the nucleus accumbens, the reward pathway through the ventral tegmental area. I feel like because ketamine helps, people will want it, but actually ketamine is a sensitization, right? So the more often you use it, the more responsive someone is to it and the less they need it, sort of like buprenorphine to a degree.
Yeah, yeah, and that's been my experience with patients. Of course, none of my patients have drowned, but they haven't had those kind of doses either. I think that you raised one very interesting. You've raised several things. First of all, I'm going to get back to the speed limit thing. The reason I was smiling while you were talking about the CDC guidelines as a speed limit, there was a period of time in Montana where the speed limit was eliminated and people were encouraged to drive under reasonable and prudent conditions.
I was there. I was at Malmstrom Air Force Base, and
Yeah.
they got me at 110 in my Mustang, and I said, "Hey,
Yeah.
I'm still on the road, man." But no, they told me, no. You go over 80, we're gonna hammer you.
Evidently that wasn't reasonable nor prudent, but it's like, okay, so who's qualified to decide if I'm speeding? The officer,
Right.
okay? Who's qualified to decide if you need this medication or that medication? Who's got the training? You do. I do. So the other interesting thing about autopsies that you mentioned that I think is really important for people to know is that if you take people off their medicine and they have no opiates in their system and they have an autopsy, great, I'm not going to jail, but they're dead because they lost access to their medicine, and you can't prove it because there's no toxicology that'll prove it for you. In other words, they have cardiovascular failure, they have a stroke, they're hypertensive. You know, the hypertension of pain is impossible to control. Just ask some of my patients, and it's easy to control with relieving pain. So this whole thing about, oh, we got to do tox screens. Yeah, people should take their medicine as directed. But the other thing that we're really missing is the number of deaths that are falling through the cracks because they don't have toxins in their system and they've died from withdrawal.
And I think that's much, much higher than people realize because there's stress-induced cardiomyopathy that everyone recognizes. But then there's opiate withdrawal-induced cardiomyopathy that was recognized in Australia. And putting someone under severe emotional strain can cause a cardiomyopathy that can kill them. And I think that there are probably tens of thousands of people that have died. 2 seconds. Computer, stop. Apologize. That there are tens of thousands of people potentially who have died, and there's no way to identify except by going back and seeing what they were on and how soon they were taken off, because it can take months to die from stress cardiomyopathy.
Not only months, but a lot of money. One thing we're really missing out on in trying to save money is that, we shouldn't treat these people chronically because it's so expensive. And it's like, it's not expensive to support somebody who's in palliative care. What's expensive is not treating them. Then they get pneumonia, or they have a heart attack, or they have a stroke, and they're in the nursing home, and all of that shit happens to them. And we're paying for it as a culture. The Institute of Medicine report in 2011 estimated a $625 billion impact on our economy, and that's $1 trillion now. And those are the impacts that we're facing by shunning people, treating them shabbily, blaming them for their illnesses, or abandoning them after. It's basically, for some of the invasive docs and surgeons, it's basically ka-ching, 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 and then kick to the curb. I can't help you anymore. What do you mean you can't help me? I've been coming to you for 10 years, and now you're telling me you can't help me? Did somebody take away your MD? Did you suddenly flunk something? What happened that you can't help me? Because I thought we had an agreement that you would be helping me, and now you're kicking me out of your practice because I'm dangerous to you. That is superstition at its ultimate. It's like we believe that opiates are bad and badness is contagious, so we must avoid badness at all costs. And so doctors are avoiding badness by saying, I'm no soup for you.
Well, and it's getting to where doctors are almost lauded for firing patients. Now, I was taught that patient abandonment was an abrogation of your obligations as a physician. That even if you couldn't help the person, you could find someone who could, and it was your obligation to help them until someone was found. There are pain committees and medical boards throughout the United States now who are telling doctors, well, how many have you fired? Did you power taper them? What's a power taper? Just rapidly cut them off. And they have said, if they threaten suicide, that's on them. That's not your problem. It is the strangest thing I've seen in all my studies of medicine. There is no parallel in history except, and I hate to use this parallel, Germany in the 30s. Yep, absolutely. Germany in the 30s, the White Rose Society. The parallels are spooky because basically, you're a drain on society, so we're going to let you die. You know, that seems to be their solution.
Well, you know what? I think that's very interesting ethically and morally for you to bring that up because I signed a Hippocratic oath, and you know, Hippocrates is who I work for, and my higher power and my patient. I do not work for, you know, some former dog walker who can do an inspection on a doctor after 13 weeks of training and indicate that he's running a scheme or a conspiracy or pushing drugs. I mean, basically, doctors in general want to help people. And when my colleagues say my hands are tied, it's like, okay, you can do that on the weekend, but you don't have to say your hands are tied to your patient. You can sit down and say, let's figure something out for you. Let's find out who's going to help you. Like maybe, oh, you could call the CDC's opioid rapid response team because they're going to help you for sure. I mean, if you go to the website, you see this little section and it has an ambulance in it and it's all this kind of very pretty talk. There's no phone number to call and they haven't referred one patient to one doctor. No, I'm doing their job.
They're just it's just there so they can say they did, from what I can see. I cannot see that they actually help anyone anywhere, or they'll give you the location to the nearest emergency room. And as we've both been emergency doctors, we know that the emergency room is not where you will get your best chronic pain or addiction treatment. And now they've been targeting doctors who treat addiction, doctors who treat ADHD, and they're saying, well, why, you know, doctors need to treat addiction and pain. Why don't you guys want to treat them? Because if we have 10,000 patient interactions, and you find 2 patients that sold some of their medicine because they were desperate, you're going to come lock us up saying we knew or should have known. And that's an impossible standard. I would love to apply it to them because the federal budget would drop by about 90%.
I know, right?
If they got fired for what they should have known, we would solve our budgetary problems really quick.
Yeah, I sort of want to get Ida May from what was that movie with where the guy dies and he comes back. Yeah. The person that Whoopi Goldberg played, and you know, she had a crystal ball.
Ghost.
Yeah, Ghost. Yeah, so she had a crystal ball, and you know, she was faking it until she realized she kind of wasn't. And you know, I got a lot of intuitive skills, and those are gifts to me and to my patients, and that's helped me tremendously throughout my career. But it's trust and verify. I mean, Reagan was right. So you know, you do what you can for patients, and you cannot tell on the first visit which patient is going to be lying to you, because there's plenty of studies that show that you know, you could have grandmas, bankers, teenagers.
It is impossible to tell, and the FBI acknowledges that when they use a polygraph, their trained interrogators are 50-50. You might as well flip a coin. There are famous cases of CIA spies or spies in the CIA that pop up in Russia, and they passed every polygraph, they passed every interrogation. And then there are people who turned out stone cold innocent whose careers were destroyed because they thought they were the mole and they were convinced of it. And I think that when someone thinks they can tell when someone is being deceitful, they're setting themselves up for failure, because you have to acknowledge it's very, very difficult for people trained in these areas. Now, one of the things that
Can I add on to that? Can I add on to that for a second?
Please.
It's worse than that, Joe. If you are suspicious of your patient, the magic that happens between you and your patient disappears, and your ability to make a diagnosis is impaired. So you have to be open and listening and have your heart open and compassionate with the patient in order to let them tell you what's wrong with them so that you can help them. So if you consider them to be a threat, you're all shut down and none of that data comes through to you. Therefore, you're operating from a checkbox system and people are getting lousy care.
Now, I have argued that also. I've argued that physicians need to have qualified immunity, like police officers, priests, and attorneys. No attorney is faulted if they defend a guilty person.
Right.
No priest is locked up because someone confessed something that they didn't turn in except for extreme circumstances. My argument is
plus no priest is locked up if if one of their clients or their parish goes to hell.
Right. They don't come and get you.
Yeah.
You know, it to a degree, and I'll also argue this. When the compromised patient or the undercover agent has to lie to a doctor to get a prescription,
that's a felony.
They are the criminal, not the doctor. If the doctor was criminal, you would not have to lie. If you go in with $1,000 and say, hey, can I have a prescription for hydrocodone? I don't want an exam or anything. I just want some to sell. And the doctor writes you a prescription, dandy. You know, still crime creation, but dandy. But when they lie to these doctors and then that person shows up in court and saying, well, I really didn't need it. And they kind of knew I really didn't need it. And they prescribed too much. And it has become where I argue that any physician in America prescribing a single controlled medication to a single patient could go to prison right now under the criteria that these doctors are being prosecuted under. 80% of them, I've evaluated hundreds of cases. I can find no crime. I can find no evidence of criminal intent. Now let's talk about that. The Ruan ruling seemed to be the Supreme Court saying if they don't have criminal intent, you can't lock them up. And that seems to have been completely ignored.
Yeah, what's up with that? I guess the Supreme Court is not an enforcement agency.
You know, I likened it to what happened to the Cherokee. They went in front of the Supreme Court. The Supreme Court said, you can't kick them out of Georgia. And Jackson said, the Supreme Court made its ruling. Now let's see them enforce it. And the executive branch sent the army in and marched them out. It is exactly the same. You know, if they are not willing to follow the law, it's very hard to make them. So,
well, don't we have a trail of tears going on right now? Then
that was what I titled my article, was the medical trail of tears, because it truly is. It truly is, because and then they're shooting the ships that try to pick up the lifeboats, because when a doctor takes in, so one doctor gets shut down, his patients scatter out. Any doctor who takes in those patients is automatically a target by the DEA. They said they're like ants from an anthill, and we just see where they go, and then we move over there and target them.
Well, and you know why they do that, Captain Parker? Because there are no narc agents anymore. It's hard work to go out on the street and try to buy drugs. It's much easier to go to an address that you're familiar with, talk to a doctor who keeps records, and doesn't shoot back. So now, I mean, basically the most efficient drug interdiction is to sit in front of a computer and find who's prescribing a lot. And you don't have to go out and get worried about exposing yourself as a false identity or getting caught in some gang that you're trying to infiltrate. You don't have to do all that dangerous stuff. You just get great results, tragic, but great results sitting on your ass in front of a computer. And I resent it.
They said, let's go where the money is and the guns are not. That was their and you know, granted, going after the cartel is hard, and you know, you can wear all your neat vests and carry machine guns and kick down doctors' doors. None of them have shot back. You know, doctors have been murdered for not treating pain. No doctor has had his machine gun saying, say hello to my little friend, when the DEA comes stomping through the door.
Yeah, I think it was Dr. Peterson in Tulsa that was shot.
That's right. That's right.
Oh, terrible.
I took a hard look at that. There was one other one too, that ended up being killed over it. So in a way, they are, now there is a law that says that the federal government is not allowed to influence the practice of medicine. 42 USC 1395 says when they came out with Medicare, the doctors were worried that the federal government would try to influence the practice of medicine. And it basically says that no federal agent or employee should be can try to. They completely ignore. But who's going to enforce it, right? Who's going to arrest the federal police? There's no one over them to arrest them, which I would argue is why the states are supposed to manage this, right? But then they co-opt the states. They go to the states. They went to the Arkansas Pain Committee and said, "Do what we say, or we're going to lock up 5 doctors." And the Pain Committee said publicly, it's on tape, we were terrified. Well, why? Unless you're criminal, why would you be terrified? Because they're going to come destroy you, whether you're criminal or not.
Yeah, they know. We all know that's the perfect storm with this narrative, that we're living in a culture that is still tied to its roots in Puritanism and Calvinism. And of course, the concern about a Calvinist is that somewhere, somehow, somebody might be happy.
Right.
You know, their religious freedom that they were seeking coming here was a stricter, more conservative form of religion, and that's the basis of most of our cultural thoughts. And therefore, we've got this consciousness that boy, if you're happy and I'm not, I gotta do something about you. And that is a problem, because I tell you what, we believe that pain. We kind of believe that psychiatric illness is a curse. We also believe that pain is a curse, that you've earned it somehow, that it's somehow karmic, and then you must have done something wrong. And the third thing we believe is that if a doctor gets in trouble, they must have screwed up.
And I have to confess that for the longest time, that was my assumption also, was that,
Mine too.
They don't go after that many doctors. Well, they don't have to, because it's called a Russian warning shot. You go into a room with 300 people lined up. You shoot one guy, that warns all the rest, right? So the Soviets used to shoot one guy, and then when they captured prisoners of war, they'd shoot one and then tell everybody what the rules were. Of course, everybody followed the rules. So that was a Russian warning shot. You shoot the first guy, that warns the rest. So that's what I feel like they're doing. I feel like they're saying, we don't care. They would probably prefer you to not be guilty, because you terrify the other doctors much more if someone is clearly doing their best and you roast them anyway.
Yeah.
So
I was always the A student, always the achiever, always the guy to get shift done, always the guy to come to. And now I felt sidelined for a while. And so, Doc, what happened to me is I started prescribing opiates again almost 2 years ago. And that's when Dr. Bakoff was cut off, and some of my activist friends were going to him, and they said, well, can you help us? And by that time, my kids are in grad school. I don't have to, and I've taken all my money. So I basically said, sure, I'll help you, because I'm already under the bus. So now I'm really getting in touch with how much of an emergency it is for patients who are losing access to their medications. I don't know how much you've looked into the opioid settlement agreement, which is a completely arbitrary rule taking and rule setting by a judge that basically deputized the distributors of opiates into kind of a Nazi kind of program where they can't even inquire. Their protocols are secret. So if you actually ask them what they're doing, they can actually just suspend your pharmacy from any scheduled drugs.
For daring to ask what the rules are. There are secret rules, and if you ask what the secret rules are, you can get suspended. I've also noticed pharmacists are telling patients, if your doctor doesn't cut you down by 20% by next prescription, I'm not filling it. Well, they're practicing medicine without a license. They're not trained to do that.
I had 3 of those conversations on Tuesday.
It is a crisis. And I understand what the pharmacists are doing, because they got locked up saying you should have known that this patient didn't need this prescription. How the heck could he know that? He knows how to recognize the pill and the powder and how to get the right pill to the right person. He has no clue, or he or she has no clue how to diagnose a disease or treat a disease. That's why they're not allowed to prescribe.
The pharmacist that testified against me in my hearings basically regurgitated the phrasing from the DEA video that they send out, where watch out for people with beady eyes.
Beady eyes.
Oh yeah,
I'm in big trouble.
Oh
I'm
yeah,
in big
yeah. It's like
trouble.
okay, it's like really you have to. I mean, there's so much superstition. In fact, my new favorite term that I just discovered yesterday about this is that we have a lot of conspiracy theories going on. This action against patients and doctors and now pharmacists is the definition of a conspiracy theory. It's false. There's no facts to it. It's implemented for non-truth reasons. You follow the money, you find the answers. It's got all of the ingredients of a conspiracy theory.
Well, or a political ideology. You know, when they used to say that you have to toe the party line, you have to do this. The number one thing, the most common last words of someone targeted and executed by Stalin was "Long live Stalin." So we have these arbitrary political decisions being enforced contrary to the law, as if they were, as medical dictates to the physicians, who are the only ones who are supposed to make medical judgments. And
Yeah,
now you've got a few doctors popping up and just singing the praises of the Inquisition, right? My
yeah,
favorite parallel is during the witch hunting in New England. A man popped up and said, "Hey, I hunt witches. I know how to hunt witches. I can identify them. I've trained my daughter to hunt witches." And then someone said, "Witch," and he ended up getting executed because he there's no
yeah,
safety once you go away from evidence-based, truth-based, and I would say science-based medicine. There is no safety, and they're confusing the average practice of medicine with the usual. And I'll tell you what I mean. These pain specialists are getting rolled up because they're saying, well, you're not treating like most doctors do. Out of 989,000 doctors in the United States, only 6,778 of them are pain specialists. So there's only 0.7%. Of course, they don't get to see the usual patient or the average patient, because that's what the primary care doctors used to take care of.
yeah,
Now everyone's getting dumped on the street, and they've got the fake the fentanyl and xylazine laced oxycodone and hydrocodone and Percocet. So patients desperately try to buy their medications on the street. They think
yeah.
they're taking what they're supposed to take, and it's not. It's fake, and it kills them.
I
And
have to ask you,
poison.
if the only thing left is a black market, can we actually call it a black market, or do we have to call it the market?
It becomes a gray market, and that's like what you had in the Soviet Union and China. Anytime you have a centralized economy and you can't get stuff, there will be stuff available. And they played right into the cartel's hands,
Yeah,
because the cartel started making fentanyl so they could make fake heroin and not have to process it from opium. And once people start dying of heroin, then they start cutting all the prescription medications, and then you get more people on the street looking for relief, and then they start taking what they think is heroin, and they start dying by the droves, because most people don't want to die. They don't want to overdose. And if they were actually taking heroin, most of the heroin users would not overdose. It's when they're
yes,
taking this adulterated stuff. Then And so now you've got the DEA restricting the production of controlled medications to the point that even when the doctor says it's legitimate, here's your prescription, and the pharmacist says it's legitimate, I would like to fill it, I can't, because there's not enough. So you're going to have to
yeah,
go without for a month. And no one who hasn't suffered that knows what that's like.
no, no. And we have this myth, at least I was trained under this myth a little earlier than you, but I was told that yeah, alcohol withdrawal, dangerous, 10% fatality, admit them to the ICU. But opiate withdrawal, you just feel like shit and wish you would die, but you don't. But that study was in teenagers and 20-year-olds.
Right.
So we don't have a study documenting the harm of withdrawal to someone in their 50s. So this whole pretense is a belief that, well, withdrawal from opiates is harmless and just miserable, and you deserve it because you're an asshole for using opiates. It's not true. It's basically unsafe for anybody over 50 to go through that kind of thing,
It is
and we're doing it
absolutely
every day
unsafe.
to patients.
We are. And young people can still die from stress cardiomyopathy in countries where being arrested is the death of your social and your social life. Japan, places like that. Young people will die from stress cardiomyopathy just from being arrested. they'll die within a week of being locked up because they know my life is essentially over, or they feel like it is. And the stress, that emotional stress can cause Takotsubo cardiomyopathy, and they die. Right? It was named
It's
in
the
Japan because they
shame
get like,
agony circle.
yeah,
Yeah. Yeah.
stress kills. No Civil War doctor would have been dumb enough to say pain cannot kill you. They knew pain could kill you, right? Because they had to take off limbs without anesthesia. They had a matter of minutes to do it in, or you were dead. And chronic pain, of course, chronic stress, and as you say, hypertension, uncontrolled hypertension can sometimes be controlled with proper pain relief, and that's completely disregarded. It is the solution to stop the medication is considered the solution. And there's no follow-up after that. And I argued with someone from the CDC. I said, it seems to me like once your intervention came into play, the death rate does this, the prescription rate does that. I don't fault you for confusing correlation with causation up to about 2010. After that, I'm saying now you're doubling down on what's obviously a false assumption. That's the most common political mistake. It's not supposed to be a common scientific mistake, but
Yeah.
they have nothing to say. They say, well, it shouldn't have been done the way it was, and that's not how we meant it to be. And I actually spoke to Dr. Chow, and I want to ask these doctors, how many courtrooms have you been in to defend the doctors who practiced according to what you wrote? Right? According to what you wrote. Because it says if someone's already on opiates, they fall into a different category. And that was how we practiced. And that's what got us targeted, was that, people were coming to us for help when they were already on opiates. And same as you, if it was reasonable to taper them down, we would. We'd try a taper anytime it was reasonable if they could get off of them. My perception is that a good physician, the best physician, is the one that makes you where you don't need to see him except once a year to get your stuff checked. Right?
Yeah. Yeah. Those are my cannabis patients. Essentially they're empowered to go out and use cannabis and figure out how to use it, realize that there's 150 different biochemical entities in the entourage of a cannabis whole weed, and that something might not even be related to THC that helps them, or if something makes them anxious, they avoid that, and they can figure it out on their own and do their own spreadsheet and then come back for their medical card. And if they do, it's because they're getting good results. That's called the scientific model.
That's exactly right. That's exactly right. And if you have a political ideology that says, we don't care what your evidence says, well, I mean, I was always mad when they say there's no medicinal purpose to cannabis, but Marinol's just fine. I'm like, that's a synthetic analog of THC. How can there be no medical use for cannabis when it's been used for 4,000 years at least as a medicine? And you guys made a synthetic medicine off of it, and you're charging huge bucks for it.
But, and the other thing is that Nixon in 1972 did a study. He had a influential white paper done that said don't criminalize cannabis. And he ignored it. I mean, and basically the data was there in 1972 when they came up with the whole Controlled Substance Act anyway. It was there.
Nicotine kills 600,000 Americans a year. Alcohol kills 48,000 that we can clearly attribute to alcohol. Cannabis kills 0. Now, it's not good for kids. If adults want to use it recreationally, I say consider it just like alcohol and smoking. It'll have side effects. It'll have risks.
Let's talk about kids.
Yeah.
So I've raised 2. And when I was in high school, 4 members of my class died in alcohol-related car crashes, and I spoke about it at graduation. So I've been in this business for quite a while, I just realized. And I said to my kids, I don't want you using any substance, but absolutely nobody leaves this house drunk. There is a gradation. This is called harm reduction, basically, which we're all terrified of, but it's the only thing that works.
Right.
You reduce the harm of whatever substances we're going to put in our mouths. And I know my kids, when they were born, they've been putting stuff in their mouths since they started crawling. And the rest of the human race does it too. Expecting people to not put anything in their mouths or not try to alter their consciousness. I mean, I do it in front of the refrigerator. It's obvious. And it's like, we're all addicted to something. What is with all this shade we're throwing at people who we claim are addicts? and we are now actually treating addicts better than pain patients, which
that
is
has been a very shocking turnaround to where
yeah,
they say, ignore the rules for addiction, go ahead and stretch the diagnosis, basically go ahead and commit fraud and put them on addiction medicine, say they have addiction when they don't, because that's okay with these pain patients. Be hard with these pain patients. And I'm thinking everything has flipped on its head, and there's no evidence or logic to it. And
yeah.
it's very confusing. Now, I think that the DSM-5, when they went to just a substance use disorder of different gradations, I think they conflated substance use with abuse, with addiction, to where they're
With no
all the
evidence.
same thing now.
And they had no evidence for doing that. I mean, if there's an opiate use disorder, and now there is, why don't we call diabetics insulin use disorder? Or angina patients nitroglycerin disorder? You know that nitroglycerin is very dangerous. You could explode. We have to take it away from you. You might be
Right?
harmed from it.
Well, it can
Um,
stop your heart and all kinds of stuff. We use
yeah,
dangerous, and that's another
dangerous.
thing. Let me say this. When they say in the newspapers, the doctor used dangerous medications and dangerous combinations, I'm like, that's the definition of a medical doctor. Safe
Yeah,
medications and safe combinations are over the counter.
yeah.
We're supposed to use dangerous medications and dangerous combinations with a risk benefit analysis to help you. And that's what we're supposed to. Who else is supposed to do it? The DEA. Here's what I want to do. You and I, as emergency doctors, I want a DEA agent. I would never really do this. This would be cold, to come in with chest pain. I'm gonna say, hang on, I'm gonna round up 12 random people outside. I'm gonna get one of my colleagues to argue that you need a stent. I'm gonna argue that it's heartburn and you need to go home. We're gonna let them vote, and whatever the majority says, that's what we're going to do with you. That's what happens when you put a doctor on trial, because the jury and even the judges have no medical experience. And I've been shocked at the lack of I would say, deference given. An MD with a doctorate of medicine will be said not to be an expert at medicine. But the DE agent with a 4-week course or whatever, they're an expert at diversion and abuse. And I'm saying, how did we get here? Right?
How did we get here? How do we get here?
It,
Well,
it, it,
we've got to turn the Titanic.
so,
We
so
can't
what are you
stop.
still doing? I know you've done a lot. I know you were featured in the film. I know you've written the book. Are you still active in anything now, trying to make a difference?
Yeah, I have several patients that were victims of the DEA action against Dr. Bakoff. I basically I'm running a lifeboat, and if someone gets in my lifeboat, I take care of them until they can find a better vessel, like either a houseboat or an ocean liner or the shore. And guess what? There's no red flags on the shore.
That's right. That's right.
So
Now, talk about Dr. Bokoff for just a moment. Dr. Bokoff is the physician who was shut down by the DEA because they said he prescribed too much medication, and one of his patients was on too much. One was on too much medication, as if everybody, there's 140 different genetic variations of the mu opiate receptor 1. There's like 80 different variations of the cytochrome P452D6. And I don't know how many for 3A4. You never see an average patient. You never do. You always see an individual who is so unique that you have to tailor your approach and your treatment to that individual. Then you got Dr. Bakoff being shut down because the DEA said so.
yeah,
And as far as I know, he's still shut down. The patients sued
yeah,
and were told they don't have standing because nothing was
they don't
taken
have
from
standing.
them.
Yeah, yeah. I know a lot of the patients that were in that. I kept track of it throughout. The arbitrariness. Well, arbitrary and capricious is a word that's frequent in some of these regulations, and the DEA has behaved in an arbitrary and capricious way to restrict Dr. Bakoff. And he had 240 patients on high doses that he was following, and they came from Dr. Tennant and Dr. Aranda and other high dose doctors who were taken out. So he was treating pain refugees also. The interesting thing to make about that is that where was he practicing?
Was he in California or Colorado?
Beverly Hills.
Oh, Beverly Hills.
Yeah. So essentially, the only people getting pain medicine now are rich white people. Okay. And then we're going to take that guy out last. We didn't take him out first.
Right, right. Well, they go to Appalachia first, right?
Right. Yeah. Yeah.
Appalachia, Arkansas.
Some town in West Virginia that got thousands of prescriptions. And, they use this tactic of counting pills, like the amount of pills are overwhelming. Well, I mean, we could count the amount of skin cells I incised when I took your pimple off.
Well,
And they would be in
here's
the
the
billions.
parallel I draw. Dr. Parker told me to drink a swimming pool's worth of water. And other doctors will say, oh my God, you'll have seizures and die from hyponatremia. So when did he do that? Well, he told me to drink 8 ounces a day, 8 ounces 3 times a day for a year. If you add all that up, that's like one of those small outside. Well, nobody does that.
Beautiful. I am stealing that. I love that analogy. I am using
absolutely.
That.
It's the same. I do the math on this. Okay. A doctor in Arkansas went to prison for, I think, 20 years. And they said he prescribed this many pills to this many patients over this period of time. I did the math, an average of 2.5 pills per month. Perfectly normal.
Yeah.
Perfectly normal. But boy, it sounds like a lot when they say it. And then they quote the morphine dose equivalents, 1 million morphine dose equivalents. And the media turns that around and says 1 million doses of morphine, and then it becomes 1 million pills. And I'm like, a morphine dose equivalent is a fraction of a pill. It's 10% of a hydrocodone 10, which is, for moderate to severe chronic pain, hydrocodone 10 used to be sort of your starting medication.
Yeah.
Right.
Now, well, I mean, why go to the ER now? I mean, you go to the ER and break something, they're going to send you home on ibuprofen, and you can get that on your own.
Now, have you read the study? And I wrote about it, where CBD and CBG not only treated pain and fractures as well as NSAIDs. This is a study. I'm not saying it to anyone out there. The study's there. I've written about it. CBD and CBG worked as well as NSAIDs and promoted bone healing instead of inhibiting bone healing the way NSAIDs do.
Right. Yeah.
So that's got to make them mad, because they're saying,
Yeah.
Now, CBG is an anti-inflammatory component of cannabis, cannabigerol or cannabidiol. And of course, CBD is cannabidiol. And these are non-psychoactive, right? The THC is psychoactive, but CBD and CBG are not. So as you say, there's a lot of chemicals, in the plant that, and we truly don't know. Everyone thought it was the THC by itself that was relieving pain and anxiety, but we find out the CBD is important also.
Terpenes, linolene, all kinds of stuff. We're babies. We're babies in that
about
research.
Cannabis. So Montana passes the Cannabis Act. Where do you go to? I went to Nevada and Colorado. Now, I will confess, I am the biggest nerd on the planet. I have never actually tried marijuana. I will not ask you if you did. 40% of Americans have, and I was a big nerd, never got invited to parties, so I have not. But I went to Nevada and Colorado, and I learned a lot about it, right? I went to these dispensaries. I went to talk to doctors, and I said, hey, give me a crash course. Arkansas just approved it. What do I need to know to educate my patients, right? Where did you learn about it? Where did you read up on it and everything?
My patients.
Okay.
They would come to me and they'd say, Doc, would you renew my cannabis card? And I'd say, no, I'm not risking my license so you can get high. But I put a comma after it. I said, just out of curiosity, why does this work for you? And they started to tell me. And they used to be on 30 medicines. Now they're on 4. They used to be on opiates. Now they're on cannabis. They used to weigh 110. Now they're 130. They used to be on psychotropics. Now they sleep without that stuff. They used to use Adderall for their ADHD. Now they use a sativa strain and they focus much better without the hangover effect. And their A1C used to be 9.6. And when they started on cannabis, it went down to 6.5. They take gabapentin and they can't, and their brain doesn't work, and they come off gabapentin using cannabis and they say, thank you, I can now go back to reading because I can now remember what's in when I'm in chapter 5, I can remember chapter 2. I can read again. So yeah, it was remarkable. It captivated me. And I wanted to scream it from the rooftops, like, how did this get omitted from my education? I mean, I quit smoking weed in college just because I didn't want any trouble. I was afraid of badness. Non-specific badness.
It has been associated with, and it's very interesting to me. my family's from a tradition of fundamentalists, and I know the Bible extraordinarily well. And a lot of my
Not in
family
there.
on that side will talk about. They'll say, we're Christians. They don't use it. I'm like, it was used at the time of Jesus. There were hemp wrappings that were used in the mummies. You think somebody back then broke a leg and said, no, 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 I don't want, no, you used what was available. But besides that, there's nothing.
Cannabis oil was used to anoint the rich.
Absolutely. And there's nothing in any sacred text that it says don't get drunk, right?
Yeah.
But they have no problem with that. A lot of them have no problem with that.
Well, let's look at Jesus specifically. Long hair, beard,
he's toast.
toga,
He's toast.
sandals. Of course he used weed. And they couldn't use it in the Catholic Church, so they used frankincense and myrrh instead. It's still incense, and it's still sacred because it brings us someplace we can't ordinarily get to. And that's why we go to church. That's why we have a spiritual life if we've got one, or that's why we reject a spiritual life if we were harmed by ours. But ultimately, we are not human beings having a spiritual experience. We're spiritual beings having a human experience.
Oh, that's interesting.
And pain, it'll suck the life out of you to make sure that you cannot have any spiritual experiences. You cannot see any meaning other than, how do I get to the bathroom from my bed?
Now, I argue that sleep deprivation is one of the main ways pain kills you.
Yes.
Through sleep deprivation, because you will break down, you will die. You cannot be healthy without good sleep, and you cannot sleep if your leg's on fire, right? So someone has phantom limb syndrome, they have severe rheumatoid arthritis, whatever is causing them severe pain. There are systems in the brain that operate to keep you awake if you're in pain, so you can get away from the pain, avoid the pain, whatever.
So Cushing wrote his treatise, I don't know, 18 something or other. And he basically found in autopsies that some chronic pain patients had zero adrenal tissue left. So they died of hypotension or adrenal failure, just because of their stress and putting out cortisol so much. They died with adrenal failure.
So it became cytotoxic, and basically their adrenal glands work themselves to death.
Yes. The typical.
That makes sense. That makes sense, dead horse. Because of course you get mineralocorticoids are released when you're in pain. A lot of things. Chronic pain is very different because acute pain most of us can tolerate for a limited period of time, and we think we know what pain is, or we are blessed to be born with high natural endorphin level, and so we assume everybody else is just weak. But until you actually experience severe unremitting pain for a certain period of time, there was a DEA agent that wrote a very touching article about the flip in his perception of pain patients when he himself developed a severe, basically untreatable pain. I can't remember if it was trigeminal neuralgia or what it was. Trigeminal neuralgia is one of the worst things you can have because there's no
suicide disease.
No physical sign. It is like your face is on fire, and everybody's going to be, quit whining. It looks fine, right? How many times have you had doctors say, oh, well, you had your back surgery, your pain should be better? The orthopedic surgeons and the spine surgeons will tell you the surgery wasn't to make their pain better unless it was a laminectomy. It was to stabilize their spine so they wouldn't get paralyzed. You screw steel into someone's bone, generally that ouches, right? Generally that hurts a little bit. So what would you, to patients right now who are suffering severe pain, if they're in states that allow medical cannabis, would you suggest that they at least educate themselves on that and go to someone who can educate them about it?
Dr. Patricia Holland wrote a book called The Pot Book. It's highly co-referenced. Lots of research. When everybody says there's no research, it's false. And the most research sidebar is that most research now in medical cannabis is done in Israel. Do you know who's paying for it?
Probably us.
The State Department. So anyway, it's a very much of a trial and error kind of a thing, and people aren't comfortable with that until I let them know that I don't give you your dose. This is not pharmaceuticals. If you say I tried cannabis and it didn't work, it's kind of saying like I tried a pharmacy once, I didn't get any benefit. So there's so many variables and so much to learn that I can't teach that, but people can learn it experientially. They try something and it works and they stick with it. And then of course their dispensary loses access to it. They got to go to a different one, all that complication.
Right.
But essentially is you got to make friends with this herb that was placed on the planet for your well-being. And then you got
there's different strains that help with, like there are some that are geared more toward inflammation. There are some geared more toward sleep, some toward nausea and chemo, some toward pain.
Yeah.
Where does
And some people are flipped. There's a racemic effect. In other words, 70% of people will be sedated by an indica, but that means 30% are not. In the same way that you give somebody Benadryl, they could be hyperactive instead of sleepy.
That's another problem. And I actually use that parallel. When I was in an ER resident, patient came in and he's dystonic, right? We said, what happened? Oh, they gave him a shot and he got like that. We're like, all right, take him in the back. Nurse gave him 50 milligrams of Benadryl IM. And so the nurse takes him back and the attending, he's showing us how to do it. And he turns to the patient's family and says, what did he take to get like that? They said Benadryl. And he's like, wait,
yeah. Oops.
Yeah, some people don't react the way you expect them to. There are people who take gabapentin and have searing, burning nerve pain. There are people who take muscle relaxers and get terrible muscle cramps and muscle pain, muscle aches. And
people who take Ambien and they sleepwalk or they sleep drive or worse, sleep shop, and they wake up a couple of days later and there's 16 packages on their porch.
And people who will take caffeine to sleep. I have seen that too.
Well, that works in ADHD patients. Yeah, for sure.
Yep. They will take a big nap. And, they say the usual practice of medicine. So every one of those exceptional patients we've talked about, and I would argue that by allowing politicians and law enforcement to dictate the practice of medicine, we are removing the room for the exceptional practice of medicine, because there are patients who are an exception to almost every rule. And the exceptional practice of medicine requires that each individual be evaluated like a science experiment, right? Because you never know what's going to work for somebody. I was one of my favorite addiction specialists. I said, well, did you have a problem with addiction? Oh, yes, medical school. I got addicted. Oh, yes. What did you get addicted to? Right, Tolwyn. I'm like, Tolwyn? You got addicted to Tolwyn? He's like, there's for everybody, it's unique. And there's something that will grab anybody if you just know what it is. Some people, it's pulling that thing and hearing the ching ching in the casino, right? For others, it's alcohol. For others, it's nicotine. For me, it was Tolwyn. They had it in a big jar and told us, hey, you get your foot starts hurting from all the running around as a resident. Take a couple of these, you'll be fine. Said pretty soon the jar was empty, and they're saying, oh, well, who was hitting the Tolwyn jar? Well, you never know who will have an issue with something. We know that when we use aspirin, we're killing about 600 people a year. So you have a stroke or heart attack, and we put you on aspirin. We know we're going to kill about 600 people a year with that aspirin, but we're going to save about 10,000. So risk benefit ratio, analysis. But you're not allowed to do that with pain medicine anymore. The risk is all they consider. You put them at risk of addiction. You put them at risk of overdose. But the risk of heart attack, stroke, suicide, that's completely ignored. And do you have any other resources that you would recommend that people look into to kind of guide them through this struggle? Because we've got to get through this. We've lost almost 1 million people now from when this started.
Yes. So I think that the challenge of being a pain patient is sort of like Nelson Mandela's 27 years in prison. And essentially what I encourage my patients to do is to milk it for whatever spiritual thing it's trying to teach us, and move ourselves up in our priority list to number one. In other words, self-care, radical self-care is the way to survive this. The other way to survive is to have a spouse who gives a shit Many of the activists I'm still in touch with, one spouse is the activist, the other spouse is the sick one. It's hard to be an activist for yourself when you're spending 24 hours a day trying to just take care of your activities of daily living. So get some partnership going. Join a group. Americans with Disability Foundation. Dr. Tennant runs a Facebook group called Doc Talks, and he gives these talks every week about just submitting to the fact that opiate, they're going for zero. So we may as well figure out something else. So he's doing a lot of research into regenerative stuff like anabolic medications, not necessarily anabolic steroids, but like he told us last night that thymosin is a peptide, a small peptide that's so regenerative, it's illegal in the Olympics. It's not addictive, and we've got to look at some of these supplements and like polypeptides, which are small enough to get into the system and contribute to regeneration of proteins, but not big enough to be digested. Too small to get through the stomach, so they have to be injected or taken sublingually. Right. So he's doing all this stuff about finding out, what kind of hormone situation are you in? I mean, if people are on opioids, it suppresses their endogenous testosterone. Right. So a lot of people on opioids need testosterone supplementation.
Yeah, you get hypogonadism and hypocorticolism, don't you? Don't you get
well, and you get sarcopenia too. I mean, basically, your muscles begin to disappear.
By the way, speaking of supplements, a new study came out saying, hey, if we inject chondroitin sulfate basically into an intervertebral disc, the fibrous part, it gets better and the pain gets better. I'm like, people have been using that supplement for a long, long time. They're just getting around to doing the study and saying, hey, it really works.
One of my disc surgeries was chymopapane. I don't know if you remember that little fad, but my neurosurgeon traded 9 patients with it, and I was the 9th. He gave it up after my case. But basically, it was supposed to just shrink the disc and dissolve it a little bit, and it didn't help. Essentially, that's part of my training, is that I've had chronic pain. In fact, it's the best training to have to treat pain patients, is to have pain that not been tortured, because that's criminal. So it wouldn't work to put residents through acute pain.
Right.
It wouldn't work. You have to have a random source of your pain, like degenerative disc disease, ruptured Achilles tendon, carpal tunnel syndrome, and all those things I've had. So that awareness of how disabling pain can be, and the blessing of how I could work as an ER doctor and still, not necessarily be able to bend over and help somebody off a gurney or something, but I could still do my job and still have my cognition because I wasn't on an opiate. That's key information for my patients. And I give it to them and I say, I'm in pain too. What are we going to do now?
Now, I know you've got an active practice and you've got work to do, but I do want to ask you, what advice would you give to physicians still treating pain? There are times when I feel like we should just stop using opiates because it's not safe. And when you get locked up, you can't help anybody. No matter how much you intended and wanted to help people, no matter how rational and reasonable your treatment was, when they come destroy your practice, your livelihood, your savings, and sometimes take your liberty, you're not helping anyone. But there are other times when I think fight back, argue for the science. What would you recommend?
Both. I did both. I can't recommend anything else. I mean, basically, I quit opiates in 2017 because I didn't want to go to prison, because I was 10 years younger than I am now, and so were my kids 10 years younger than they are now. So I couldn't risk it anymore. It was obvious to me, the writing was on the wall. And I did it as sort of a form of protest also. I said, they're not listening to doctors. Maybe they'll listen to the patients. And the only listening to my patients happens when I let everybody know that 6 of those patients died. 3 by gunshot wound, 1 with an amitriptyline overdose, and 2 by alcohol complications. And alcohol works for pain.
I did the math.
Alcohol works well for pain.
Alcohol works for pain, and I have found that the surge in alcohol-related deaths during COVID-19 started before the virus hit. It was not COVID-19 mediated. It was pain mediated, because as people were thrown off their pain medications, I had patients tell me, I'd say, hey, you tested, we would test for alcohol byproducts. I'm like, hey, you tested positive. Are you drinking? Because, you can't be drinking on these medications. That you're tapering them down. You've had to taper them down because of the recommendations. And so I've had to start drinking again. And I had a patient tell me he had been sober for 20 years and he's drinking again because he cannot get pain treatment. And I think that's a horrible trade-off, right?
Well, you take any addict and you put them under stress, they're going to relapse, which is why the 12-step programs work to the extent that they do, is that they provide a spiritual, guardrail for people and a community to hang out in,
Someone
and
to call, yeah,
and support and all that stuff. And you take an addict and you put them in pain, and you don't think they're going to relapse?
Well, and
nuts. It's insanity.
Asking a human being to tolerate indefinite agony is a crime against humanity, in my opinion. You have to find some way to help that person. And once someone has been on opiate medications, there are changes that take place that don't just snap back to normal. So you can say from the future forward, prescribe a lot less opiates. But what you should not have done, speaking about the government, is go in and tell doctors, just stop, because that will solve this problem. Now the death rate skyrocketed. We've got all these people dead. We've funded the cartels, and now we're in a terrible situation, just like prohibition. And nobody drank beer during prohibition. Why drink beer? You're going to drink.
You had to drink harder stuff,
gin or vodka, because if you're going to do something bad, you may as well make it worthwhile, right? That was their thinking. And
whatever you prohibit creates stronger structures, stronger molecules. Opium, not very strong. So we prohibit it, we get heroin, etc. So it's the same as the beer and the alcohol analogy. I really think we're harming so many more patients than we can even measure.
Now, your book is Dr. Bison's Fables, and
yes,
there's a subtitle to it, and I don't have it. An allegory of the American pain refugee crisis. Dr. Mark Ibsen, Ibsen, and I'm going to put a link to it in the description.
Yeah.
And then the movie is called Pain Warriors.
Pain Warriors.
You're in that, and I have watched that. It's an incredible film. Do you think we need to do an okay, I argue that Pain Hustlers is to our era the way Reefer Madness was to the 60s and 70s and 50s, right?
Yeah.
Because they wanted to demonize cannabis so they could go after that subpopulation of anti-war protesters and black people that used it. They said, Nixon's, I think it was his attorney general, said, well, we wanted to get the blacks and the anti-war people, so we got to go after cannabis and heroin. He confessed to it right there on camera. And now we've got Dope Sick, which I thought was a pretty good movie. Then you get Pain Hustlers, I think it was, which is, I think that's the one with Matthew Broderick about the Sacklers. My argument is, are they selfish, greedy pharmaceutical executives? Welcome to the world of pharmaceutical companies. You could have chosen any one of them and demonized those companies almost the same, right? The Sacklers might have been. It's
just scapegoating 101.
Yeah, it's just picking someone to toast. And I think the same thing with those ADD doctors being targeted in California, Cerebral and Dunn Health. I think the government just said, hey, we want to scare everybody doing telemedicine. And if you focus things down and boil it down so you have an efficient system and you're treating a lot of people, we're going to hammer you. So I think that's what that is. Do you think there needs to be a new movie? Because the last one, and I enjoyed watching it, it had Captain America in it, but it was so far over the top. Doctors dancing in the Bahamas because patients are dying on opiates, when actually 75% of all deaths, well, 79% now, are from fentanyl that comes across our borders, and now xylazine. It was never the prescriptions to start with. It's definitely not now. Do you think there needs to be another movie? Something that shows what these patients are suffering?
Well, yes. Yes, I do.
Two of Dr. Bokov's patients committed suicide, right? A husband and wife?
Yes, and 2 others died subsequently. So 4 people have died. what I want to have is, I participated in the Pain Warriors movie, which sort of stated the nature of the problem. But I want a movie with a happy ending. Pain Warriors doesn't have that happy ending. And I think the happy ending is we restore the sacred physician-patient relationship. We move the legislators, administrators, regulators, and law enforcement people out of the exam room. And we allow doctors to be doctors and patients to be patients and pharmacists to be pharmacists. And we do the right thing for the person who's in front of us, the specifically designed thing for the person in front of us. And soon that will be by genetic profiling anyway. I mean, we're going to use genetics to the patient's advantage eventually, if it ever gets off the ground. But one genetic thing that's to the patient's advantage is to realize that less than 5%, maybe 1% of patients metabolize opiates extremely rapidly. Well, we need that information out there. It's 20-year-old research, and most of my patients are now ultra-rapid metabolizers, and it frightens the pharmacist and it frightens the doctors, and everybody's afraid of these doses. But that's kind of like saying, I'm afraid of the stove. We're going to get rid of that thing. We're not going to have anything cooked in our house.
Here's what I argue, and it'll make some of the genetic testing companies mad. I've been talking to the CEO of Averted, Solved Health, and I think Averted is useful information for the doctor and the patient to know if it's protected and not used punitively and all that. At the same time, right, I think that a full genetic reading should be done one time, Medicare, Medicaid, all insurance companies, on every patient. And then you can, as you learn you can run the scan as you learn new information on that full genetic readout. It costs about $1,000 to get a full genomic printout. I think. But
imagine the side effects we would avoid if we could find out that
aspirin people wouldn't die. You can differentiate those who need aspirin from those who don't based on these, their different unique enzymes and all that. Now, would you do me a favor? Would you reach out to the director, the producer of Pain Warriors, and see if they're interested in doing another film? Because I can put together a team of physicians. Dr. Rafai, perhaps we could beg him. He's a psychiatrist who was just acquitted in Pennsylvania, prosecuted for doing psychoanalysis. The DEA said, the federal government came and said,
well, there's no scientific proof that works.
Well, they said, psychiatrists don't do psychoanalysis. That's for the psychologists. He said, who told you that? A psychologist. But they're enforcing it if it's law. As if it's fraud for a psychiatrist to do psychoanalysis when it was an MD that dreamed it all up. Freud was a neurologist. But anyway,
one of my thoughts for another movie would be a cartoon version of Dr. Bison's Fables. So the thing that has appeal in that book, and this is what the readers have told me, is that it's not as confrontational as the doom and gloom that you and I are talking about on a daily basis.
It is very hard not to be bitter, and not to come across as strident and somewhat conspiratorial, right? Because you have all these things coming together in a perfect storm of terror.
Perfect storm. I've used that term a lot. Yes.
But most of the individual players truly think they're doing the right thing. The individual DEA agent thinks he's targeting these stupid doctors because we're out here watching this guy sell his medicine on the street, and the doctor had to know. Well, no, a negative drug screen does not mean automatic diversion. There's so many things that can cause it.
It means you're a rapid metabolizer. That's what it means.
But not to them. I have heard them say that it is absolutely diversion if they have a single negative drug screen.
Yeah, it's false. It's like bogus. It's so superstitious as to put us in mind of the Spanish Inquisition.
And I always say nobody expects the medical inquisition. So that's truly where we are. Truly where we are.
This has been a rich conversation and overdue, clearly. This is like that movie, My Dinner with Andre. We could make this go on for hours and hours and hours. And I want to tell you how much I admire you. I admire your advocacy. I admire your spine.
Thank you.
And this is a weird thing to say on a video, is you got balls.
Thank you, sir.
And hoo-ah.
I always say the Marines didn't teach me how to surrender. Perhaps they should have.
No.
They didn't. But I want to thank you for your time. you have been in this for 10 years. You know, you've been fighting this for 10 years. Your experience and what you've seen is invaluable. And you speaking out through your book and by taking part in that movie, that's brave to do, because
Thank you.
they say everyone must keep their head down, but I always argue that's how soldiers lose wars. If every soldier keeps their head down, we automatically lose. You've got to come
Yes.
up and take the shots that you can. And you have clearly.
Well, and my girlfriend Susan has a great quote. She says, "When thinking stops, the unthinkable can happen."
Oh, that's absolutely true.
And that's what we're doing. We've stopped thinking about things. We've stopped talking with each other. We're just tattling on each other, and we got to shift it, and not just in the medical field. It's a reflection of our entire culture. We have to pull together and realize that, you know, Pogo was right. We have found the enemy, and it is us.
It is us. It is us. Well,
Yeah.
thank you so much, Doctor. I won't take up any more of your time, and I appreciate
Oh man, I
it so
can't wait
much.
to talk to you again.
We will
Yeah.
chat again, and you have a wonderful night.
All right. God bless you, Captain Parker.
Thank you, sir. You also.
All right. Thank you. Bye-bye.
Bye-bye.